Hello, I'm Lorie Karnath, the Managing Editor of Molecular Frontiers Journal. I'm here today with Dr. Carolin George, known to most as Dr. Carol. She's the head of community health and palliative care, as well as research for the Bangalore Baptist Hospital in India. Welcome, Dr. Carol. Maybe you could tell us a little bit about yourself and how you got to where you are.
Hello, Lorie, and thank you for the opportunity. It's a pleasure. I'm Dr. Carol. I head the Community Health and Research Division at Bangalore Baptist Hospital. The hospital is a 340-bed tertiary care hospital in Bangalore. The institution upholds the principles of healthcare excellence and equity by committing equal importance to the state-of-art precision specialties and also to the core primary health services. So we have services which are ranging from the organ transplant to delivery of preventive healthcare services in slum. Now, Community Health Division, it's the outreach arm of the hospital, and we reach out to million population in rural villages. And also for me, my passion is universal access to healthcare and health equity, scientific advancements to suit the needs of the most vulnerable and finding ways to make the care accessible to them.
So when COVID hit your area, it created a particularly difficult situation. Protocols that were easily implemented elsewhere were especially difficult. Distancing, even masking was sometimes tough. Can you describe a little bit what you encountered and how you overcame as much as you did?
So as you said, it was really tough. Many things which could be implemented in other parts of the world, it is very difficult in India, especially in the settings, the community health and low resource settings. So just take the examples of slums. In those areas, the social distancing, like in a square kilometer, more than 50,000 people live. So there's no concept of in terms of social distancing there because, people are in a small space, 10 to 15 people. And then, that's pretty much it. They can't go somewhere else. And also hand washing. Water comes once in a week in most of these places. So, even if they use masks, how do you wash them? And it's like billions of population. I mean, in millions of population stay like these conditions. And when COVID came, it was like these population. What do? There was a lockdown, and there's no way that they can actually earn their livelihood. And all these measures like ventilation, social distancing, and even hand washing was practically impossible. However, in terms of these are the very low resource setting, but in other places also, we know India is a country of 1.2 billion. So anywhere you go, there is a big crowd, So and also the houses, since the population density in cities are high, the ventilation is not very proper. So when COVID hit, we have to manage with whatever we have to, and then hope that nothing happens, So that's what we did. Yeah.
Yeah. So you were the lead author on the Molecular Frontiers Journal article on airway hygiene in children and adults for lowering respiratory droplet exposure in clean and dirty air. Maybe you could tell us a little bit about how this study came to be and what you encountered, and we can talk a little bit about the results as well.
The first thing I encountered is like, as I was describing to you in the first pandemic surge in India, we had to use whatever we had, and then there's nothing much we could do in terms of the ventilation and the distancing sort of thing. That is when I came across fend, the calcium rich hypertonic salts. We were very much at that time, in terms of contemplating about the how do you prevent the aerosol spread, and when all other things are not possible, and then previous studies in terms of animal and other experimentation, which actually gave a lot of promising results. So I was very excited because in the settings that we work, if you could do this simple measure and it can reduce the aerosol generation, that would be fantastic. Even though I was excited about the idea, I was not very sure whether it will work in the real life setting. So during that time, we started the study. The study was in like 40 volunteers, healthy volunteers. So 20 of them got saline and 20 got the fend, that is the calcium-rich hypertonic salts. We actually found very exciting results. First of all, what we found is compared to the other cities in US where the study was done, we had a higher biosol emission. So one is the particulate matter in the environment itself. I mean, it was more dirtier compared to the other place. That is first finding. Second finding, people in India, when they're exposed to these polluted environment, we emitted more, we can be considered as more super spreaders compared to the other setting. Like if you really look at the values, when around the highest emitters in US, when they emitted around 500 to 1,000 particles per minute, our particulate count was around 30,000, the average. Yeah, so it's huge. So that's another exciting thing, that one is the air quality is compared to other place, it's bad or it's worse. And second is the amount of particulate bioaerosol emission is also more compared to other. What we found when we introduced fend, what we found is in 99% of the cases, the bioaerosol emission was reduced. I mean, it also suppressed to 90%, which is quite remarkable. So that, at that time, there was no, it was all healthy volunteers, but that gives a very important lead saying that if there is virus, that means that has a huge, advantage in terms of it prevents you from spreading to others. Also, it prevents the aerosol from getting into the lungs and give you, severe disease or things like that. So those were the findings of the first study. And also in cases of like children and things where they're exposed to these kind of settings, we thought this could be a big application because you can't change the quality of air. I mean, it's quite difficult, but this is a simple measure which, can have a significant effect.
And you focused in your later studies, especially particularly on children, is that correct?
In the second study, no, I mean, the new study which we are planning, that is we are planning to do it in children, but the second study which we did is the one in which COVID patients, we did it on mild and moderate COVID patients, and actually we wanted to see what is the effect of this, this fend on them.
And can you tell us a little bit about what the results were in that study?
In that study, what we did, this happened in the second surge. That is pretty much, it was Delta. And what we have found is, again, the first finding was the amount of particle bioaerosol generation was higher than compared to the earlier subjects, which was pre-Delta period. That is one thing that we have noticed. Second thing is, we have given half of the people normal saline and half of the people with fend. And what we noticed is, when we used fend, there is considerable reduction of severe airway disease. That is the use of steroids, also use of IV antibiotics came considerably less. We also found that the oxygen saturation was higher in the patients which were given fend. And the third thing that we found is the aerosol suppression also happened in most of the cases. So that was pretty remarkable, and we could see the difference between the saline and the fend. And fend clearly had a more advantage or stated effect in the COVID patients.
So when you mention fend, you're talking about the saline and calcium
yes.
solution. And so can you describe a little bit how that works?
So how in the study, what we have done is, it is a hypertonic calcium-rich salt, It does not contain anything in terms of, it's just the salt, so it comes under the category of nutraceuticals, or it does not have any medicated particles, so it can be used without any side effects. And it's very easy, where you can just administer like a puff kind of a, how do you explain, in terms of a, like a spray, and then you inhale. That is what it, I mean, you inhale the salt. That is it's a very easy, even for the people who had breathing difficulty also, they could easily do it. And how we use is, we used it 3 times, morning, afternoon, and evening, 3 times. That's what we have used. And in terms of the effect of how does it work, actually this divalent, this salt, it will stabilize the airway, hydrate the airway, and make it more stable. So it allows the mucus to do its normal work, which actually prevents, in this case, has an effect of reducing the bioaerosol. And also, if the bioaerosol is reduced, the viral transmission, that is from one person to another, and also transmission from the upper airway to the lower airway, is reduced. So that's how it works.
Now, you said in the second study that you noticed even higher emissions. Now, do you think part of that is due to the Delta variants?
Yes, we had the, when we looked at the particle count or bioaerosol emission, so we had samples which we collected in December, January, February, March, April, May. So, I mean, we had various time periods. So the sequencing data says that any data, any of those sample subjects after March, that means in the early April and after March, was mostly 80 to 90% predominated by Delta. So, and when we looked into the bioaerosol emission, we found what we saw towards the later, that is post-March, the average aerosol was very much higher compared to the pre-March subjects. And so that's how, and there are statements from the government which said after March, it was pretty much 80 to 85% of the sequenced samples were all Delta.
And so in these second study, what was the age groups? And I think you've described a little bit the socioeconomic groups of testing, and the air quality within the areas that you mostly focused on. You could talk a little bit about.
In the second study, what we have done is, it's the age group above 18. All participants, all patients were above 18 and who had a diagnosis of a confirmed diagnosis by PCR, PCR that they have established COVID, and also have either mild or moderate severe disease. We did not take. That was our inclusion criteria. And these patients came from in and around Bangalore, from multiple socioeconomic backgrounds, but most of the data from the area shows the air quality was, not very great. It was kind of bad. And in terms of, that's what we didn't have any children, because children didn't have very severe disease, or so they mostly didn't have much of hospitalization. So what we've taken are about 18 years in our study.
And did you note anything during the study that helped to increase the efficiency of the administration of the calcium salt? I mean, was there, you said you did it 3 times a day. Was there, did you look at it 2 times a day, for example? Is there anything else you can do that helps augment the results, or what did you see or think?
So in the first study, when we actually looked at how long the effect lasts, and we found that it's like 6 hours, and then, but when in the second study, we didn't have much thinking time. It was in the middle of the crisis where people were just brought in. People were like, we had our the classrooms converted into hospitals, temporary shift hospitals. We had the ER is full, and then patients, even the ventilators in the ER, and then you have people in ambulances, and where you go, and we were just declaring death like that, in that middle. So my thought first came is, what if fend or the calcium salts are effective. I mean, if the patient in my mild to moderate category, they're coming to the hospital because they have some conditions in which they cannot be managed at home. They are diabetic, or, their inflammatory markers are high. There's something which is happening which they cannot be handled at home. So they're coming, and if they escalate, I really know that there is no place for them to go because the ICUs are full. So in that thing, I thought, what if the fend is effective? What if it just prevents it from becoming worse? So, and what frequency? I didn't have much thought. Maybe we could have thought of multiple frequency and trying it out. But at that time, I thought like morning, afternoon, evening, that is kind of a pattern. Most even maybe it would have worked maybe morning and evening too. But I thought this is not anything. It's just the salts. It's not going to cause any harm. But if it has an effect, let it has a good effect. That's what my thought. And then we administered, and it was also easy for people because 3 times they were served food. So before that, it formed a pattern for them. And then the nurses and an independent team, not the clinical team, the independent research team, administered this. And the clinical team evaluated, and they didn't know who was getting the salts or the saline. So they were just looking at the clinical parameters and making treating decisions. So that's what the 3 times. Maybe I didn't look for multiple, in terms of intervals. And at that time, when we were doing it, we could feel that when you go to people the next day and the next day, people were feeling symptomatically better. Even though when you look at at that time, oxygen saturation and all, when you look at it, you don't think about fend. At that time, you're thinking the patient is going to go to the ITU or here. So that's mostly we think about patients. But when again, after that, when the data is collected and looked at it, and yes, there was a difference in every parameter. So that was really incredible.
Okay, and in the second study, were there confirmed Delta variants there, or was it an assumption because of the timing and did you notice a greater efficacy or similar to the first study? If you could comment on that a little bit.
Yes, the first thing is it is an assumption based on the time period, but because it was hospital, some of them, like in terms of, I know at that time it was totally different personally also, because in the first wave, I had treated more than maybe 1,000 patients and then had gone into the slums and everything where I could have contracted. And then I had 2 doses of vaccine. And in March, I became positive. That was in March. And then I knew that it was different from the first wave. And I took the samples, kept it. And once I became better, we sent it for sequencing. And it came as Delta. That was on March 25th. And, and then I was one of the first cases in the state with Delta. And then we actually took some of the, a subset of the samples from the hospitals and sent for again sequencing. And most of them came out to be Delta. But in terms of the study subjects, at that time, we didn't look into whether it's Delta or not, but I have a feeling that it was mostly Delta. Yeah.
Mm-hmm. So based on your experience and also the results, mm-hmm. What are your recommendations versus protocols overall, but airway hygiene in particular?
I would say that this is an incredible result in terms of considering the Delta and considering the circumstances at which we actually got this result. I mean, it would have, I mean, we could not palpate, but at that time it would have, helped people. I mean, would have saved lives if at that time escalation means there's no bed and, and it's kind of leading to death. So in that case, even though I cannot point out, but then I know that personally it had a big effect. Now, if you think about the application of this, it is a simple thing that can be used as a part of airway hygiene. The quality of air here is not anything great. And then you have microbes, multiple type of microbes. One is SARS-CoV-2, but other than that, you have TB, you have multiple influenza, also a lot of airborne diseases in terms of asthma and things like that. So this is an airway hygiene where we are talking about stabilizing the upper airways and making it more healthy, and especially for kids and anybody also in a very low socioeconomic status where there's no other options. This is something which is going to improve their life in various ways. So going forward, I'm also thinking about the other study in which we're thinking about children. In adults now, people are getting vaccinated. After that, one of the susceptible population would be children, and knowing that the air quality is poor, and then the infection and multiple viruses, or maybe the SARS-CoV-2 is also lingering in the atmosphere. When they go out, now it's in lockdown, and when they go out to schools and things like that, children are not going to wear masks. In that case, this can be a big, boon for them, where a simple airway hygiene thing, maybe 3 times or maybe 2 times, we can look at multiple options, but if used, may potentially help them from getting the disease, and also may have improved school performance and things like that, because asthma and other bronchial asthma and TB and other things are also there when we look at child health. So I feel that it has a huge implication in the future.
I was going to ask you, but you pretty much answered it. It goes well beyond the concept of airway hygiene, goes well beyond the current issues that we have and challenges with the virus. So it potentially applies to all pathogens in the air. And as you said early on, air is a very difficult thing to improve or control, even though we have to work on that for sure.
Yes, that's very true, Lorie, because you cannot change. It's more systemic. If you want to change the air quality, it is like it is in terms of the entire society has to change. The industrialization, industries, waters. There's so many players there, and it takes longer time to change. But you are saying that in terms of you have something which actually it's like cleaning your hand or something. It can just cleans the airway, and it gives the air health in terms of for people. Then it's incredible, and it has long-term effects in terms of increasing the productivity, school days, and also reducing the sickness time. In India, most of the health expenditure, we don't have health insurance. Like only 5 to 10% of Indian population have health insurance. That means most of the people are going for out of pocket spending. So if you're not becoming sick, that's a huge saving. And people from low resource setting, when they become sick, they do not go to hospitals. So they harbor the infection, they transmit. And most times when we actually see them, it's at a later stage. So this can be a good intervention where the cost also is not, it's a simple measure. And also I'm very excited that it's not very, costly. So that makes it to be, more useful for these population. I mean, for any population for that matter, to use it as a preventive or a hygiene intervention.
You mentioned, for example, hand washing, and we do that on a regular basis. I know it's not even possible in some of the areas where you work, but there was a lot of resistance at one point about hand washing. People didn't think that that was an important protocol. Now we take it for granted, and we understand completely that it's important to keep your hands clean. So in a way, what you're advocating is that we also keep our nasal passages clean, especially in view of what's happening in the air around us.
That's exactly what I'm trying to say. Yes, Lorie.
So I would just want to thank you, Dr. Carol, for all the amazing work that you're doing and the time that you took to speak with us today. We greatly appreciate your article, and we look forward to hearing much more from you about your upcoming studies. And thank you again.
Thank you, Lorie. It was a pleasure.